Good morning, everybody. Thank you so much for having me. My name is Shakirat Salvador. I am a transplant hepatologist at Vanderbilt. So I definitely appreciate this forum for allowing us to be able to kind of get together and understand different perspectives as it pertains to liver disease. And so as a physician, I would be remiss if I didn't explain what liver disease is, and also what tends to happen pretty much every day on when patients come to my clinic to seek help. So I just wanted to chat about that. This is supposed to be an open discussion, so if there are any questions or thoughts that you want me to elaborate on, or if you wanted to speak on, please stop me and let me know, and I'd be happy to do so. So moving on with my talk today, I have a list of objectives that we can kind of skip over, but essentially we're going to talk about the entire spectrum of liver disease, okay? So I want to start from the very beginning because a lot of folks come to my clinic, and instead of frequently asked questions, I'll say not infrequent questions. The main reason is because I wanted to tailor this for everyone, because I find these questions over and over and over again in my clinic. And I'm not sure why there's a stigma, why people are afraid to ask me these questions sometimes, but I just wanted to make sure I break that stigma and say this is an open forum, and these are tons of questions I get day in and day out, and you're not alone. Questions are okay. In fact, questions are welcome, because it's not my body, it's your body, and I want to make all of my patients the experts at them. So that is my goal with every clinic visit, and I know for the sake of time and things like that, I can't answer all the questions from the beginning of time, but I did want to highlight these questions because I do get these on more than one or two or many occasions in my clinic, okay? So we'll start off by saying, what does the liver do, okay? So I think we have a good perspective about liver disease at this point in time, but what does the liver do and where is it located? So the liver is located on the right side of the abdomen, primarily the upper part of the abdomen. It actually sits tucked under the lower ribs. So whenever we talk about the liver, that's essentially where it is in the body. And so that's why whenever you see a doctor, they'll kind of press on your abdomen to try to understand the size of your liver, the texture of your liver, and things like that. So I just wanted everybody to know where their liver is in relationship to their abdominal cavity. And so in talking about the basic functions of the liver, this is what a normal liver is supposed to do. So I always call the liver the workhorse of the body, because the liver does a lot of things that we don't really appreciate until the liver is struggling, or unfortunately when the liver is failing. So I wanted to highlight it as the workhorse of the body, because a lot of times attention is given, rightfully so, to brain, heart, and kidneys. But the liver actually has a lot of functions with every single body system you can imagine. The main functions of the liver are detoxification. So with every toxin and substance that your body comes into contact with, between the liver and in some part the kidneys, the liver has the job of detoxifying it. That means the liver sorts out and filters and keeps the good and processes that so that you can have the beneficial effects of the good, and then it tries to get rid of the bad things. So all those toxins that we get worried about with certain medications or substances, it tries to get rid of those so it doesn't cause harmful effects to the body. As far as filtration, similarly, again, part of the detoxification and filtration process is to make sure that if you're taking medications or things like that, you get the actual beneficial effects of those things, and that, again, the bad washes out of the system. It manufactures a lot of proteins and compounds that help your body go. Not just proteins and compounds that help your brain, but also your blood counts, your immune system, and things of that nature. And then storage. This liver stores a lot of important substances, primarily certain vitamins, including fat-soluble vitamins like vitamin A, D, E, and K, but also it's a storage house for sugars as well. So usually we think of having good sugar balance with nutrition, but when you're in a fasting state, your liver is actually the place that stores a lot of those sugars to be released whenever you need more. And then it actually creates bile. So one of the things that the liver does is aid in digestion as well. So whenever you are eating certain types of foods, specifically fats, those need to be broken down into its beneficial effects. So the liver is actually what creates bile. which is traditionally used to break down lots of fats in the body so that they can be beneficial and provide nutrients and help you go. So when the liver creates the bile, it actually stores it in the gallbladder. So people think, oh, it's the gallbladder's job to do that. No, not necessarily. I call the gallbladder a glorified shopping bag, because whenever the liver produces bile in excess, it's stored in the gallbladder, which is why you don't actually need a gallbladder to live. So it's really the liver's job to produce that bile. And when things are working well, the liver produces it, sends it to the gallbladder. Gallbladder squeezes when you have a fat-rich meal, and the digestion process continues. So when things don't go well or work well with the liver, that's when you start to see issues with bile accumulation. And I'll talk about that a little bit later in future slides. And then temperature control. Again, along with the brain, the liver creates lots of chemicals that helps keep your body in balance. So the liver, again, workhorse of the body, helps your other organs do their jobs and helps you stay healthy long term. So, do you need a liver to live? And hopefully that slide helps you understand that absolutely, you definitely need a liver to live. In fact, when you think about the liver and all its jobs, it's not hard to determine that the liver is essential to life. In fact, you cannot live without your liver. There's actually no liver replacement. There's no liver dialysis. There's no machine that you could put in a bag that will replace the function of the liver, which is why liver disease is so catastrophic, and all of you understand more than I how catastrophic liver disease can be. So absolutely. So what does elevated liver enzymes mean? So I wanted to start here. So what are the first signs of liver disease? And honestly, because the liver is such a workhorse, sometimes people don't actually feel when there's an initial problem with the liver. So whenever folks go and get their routine labs, or there's some labs done for a different reason, oftentimes that complex lab panel will include liver enzymes. So I wanted to explain some of the first alarm signs of the liver not functioning or having difficulty and struggling. So the 4 liver enzymes that we mostly look at are the ALT, which is the alanine aminotransferase, AST, which is, sorry about that, technical difficulties. It's okay, we'll talk through it. The AST, aspartate aminotransferase, the alkaline phosphatase, which I labeled ALP, and the bilirubin. Okay, so these are the 4 main liver enzymes. So when the liver is irritated or stressed out, when these are elevated or abnormal, these are some of the first signs that the liver is under stress. A lot of times when these are elevated or abnormal, you don't feel it because, again, the liver will continue to do its function. So these are some of the labs that when you get your labs routinely, these are some of the labs that are important for us to understand what's going on, okay? So this is the first sign that, hey, maybe the liver's under stress, maybe there's something we need to look for. Maybe we need to understand what's going on here. And there's many reasons why folks can have abnormal liver enzymes, and that's why it's really important to identify this early so that if there's any form of disease that can be reversible, we try to identify it and reverse it early. Now moving forward to the next question that I get, well, I'm not an alcoholic. Why do I have liver disease? And I would say that of these series of questions that I have on this slide, this is the one that I get the most. And so because of that, I wanted to spend a little bit of time not just talking about our area in southern eastern United States, Tennessee, but I wanted to look a little bit globally, because you're not alone. You're not the only one. This is not just you, okay? There are millions of people living in the world with liver disease. And of those millions of people, a majority of them don't actually know that they have a form of liver disease, okay? So I put this slide about the epidemiology of liver disease, not just around the world, but in the United States, but particularly within the United States, not only do people have a form of liver disease, but it's actually one of the leading causes of death within the United States as well. Okay, so it is something that is of the utmost importance, and I wanted everybody to understand that it's not just alcohol use or alcohol-associated liver disease that's contributing to the significant global burden of disease, okay? With the shifting pandemic, as was already mentioned, we saw a steep rise on the incidence of alcohol-associated liver disease, but we also saw a steep rise in the incidence of what was formerly called non-alcoholic fatty liver disease as well, particularly in women. So it's not just that. And then viral hepatitis as well. Now, when you look around the entire world, actually the most common causes of liver disease are, as I mentioned here, chronic hepatitis C virus, chronic hepatitis B virus, alcohol-related liver disease, and non-alcoholic fatty liver disease. So around the entire world, these are the most common causes of liver disease. And then there's other causes of liver disease, as I mentioned here, among others. So autoimmune liver disease, or autoimmune hepatitis, is a form of liver disease that occurs because the body's immune system is dysregulated. So the body now thinks that your liver is a danger, a target to destroy. And so that's what causes the disease over time, and that can eventually lead to cirrhotic stage liver disease. Other forms of liver disease are other forms of what we call autoimmune disorders, meaning for whatever reason, this dysregulated immune system has decided that other parts of your liver or your bile ducts are now danger zones and targets to attack. So primary biliary cholangitis and primary sclerosing cholangitis are also forms of liver disease that we have seen that can contribute to long-term liver disease and cirrhotic stage liver disease as well. Hemochromatosis is a disease that can lead, is an inherited or genetic condition that can lead to iron. Believe it or not, iron. Yes, that iron where we tell you to make sure you have enough of it to bulk up your blood counts. Yes, but this is not the same. Hemochromatosis is an inherited disorder where your body, for whatever reason, has decided we can no longer process iron accordingly. So if we can't process it, what we're going to do is store it. Think about your kid or your teenage self when mom told you to clean the room. And you're like, well, I don't feel like cleaning the room. I have too much stuff. And what did you do? You shoved all that stuff under a rug, pushed it in the closet in the hopes that mom wouldn't see. So essentially, that's the same thing that's happening to your body with iron storage in this particular disease, is that your body says, we can't get rid of it, we can't process it, so we're going to store it. One of the storage sites happens to be the liver, among other organs as well. Another metabolic inherited disease is called Wilson's disease. That's an abnormal storage of copper. So again, similarly to iron, the body cannot process or metabolize copper as well, and so it stores it into many organs, liver being one of them as well. And then there's other what we call vascular diseases, so even blood clots in blood vessels around the liver, if it compromises the liver's blood flow enough, can definitely contribute to liver disease or cirrhotic stage liver disease. And then unfortunately, even in 2024, there are some cases where we just don't know. We have no clue what caused the liver disease, but we do know that people are struggling and suffering from these symptoms. So I just wanted to emphasize that this is just one slide that if I could reproduce and send to all my patients, this is it. And this is why when we diagnose and catch liver disease early, we hope to understand what the cause is, because if we can address the cause of the liver disease, our hope is that we can stop the progression, or if it's already in its advanced stage, at least stabilize the disease. So alcohol is not the only reason why folks come into our clinics with liver disease. And so looking at some of the epidemiology, I won't spend too much time on this, but again, where you live also matters too, because the way we think about liver disease across the world is different. And so in certain endemic areas where there's a lot of viral hepatitis, our thinking shifts. So there's hepatitis B around the world, particularly in Africa, sub-Saharan Africa, not necessarily as much as the United States. Similarly with hepatitis C virus, now you're seeing that a lot more folks within the United States are afflicted with hepatitis C virus as well. So again, the cause of the liver disease matters because we need to understand the cause of the liver disease in order to hope that we can treat it early enough. And then when we think about alcohol-associated or alcohol-related liver disease, again, we're actually starting to see rises of that in places like West Africa and Sub-Saharan Africa, Europe, and India as well. And then when we think about metabolic dysfunction-associated steatotic liver disease, mouthful, or what was previously called non-alcoholic fatty liver disease, this is actually now, we know COVID was a very catastrophic pandemic, but this is a pandemic that has been going on for many years. In fact, a quarter of the world's population has a form of, I'm going to say, non-alcoholic fatty liver disease, just for the sake of, me not creating a tongue twister for myself. But essentially, over a quarter of the world's population have a version of non-alcoholic fatty liver disease, and that's actually on the rise. So Moving on to my next set of non-frequent questions, we want to talk about fibrosis because there's a spectrum of liver disease. Not everybody who comes to see me in clinic has cirrhosis. There is a big jump between having no liver disease, no fibrosis, to complete scarring, which essentially is cirrhosis. So I wanted to talk about staging, primarily because I get a lot of questions about what stage am I? Where am I? What does this mean? So I wanted to explain what that means. And so whenever we start with liver disease, something causes inflammation or irritation to the liver. We talked about that a little bit earlier. Sometimes liver enzymes can be elevated, sometimes they may not. But long story short, if something is causing irritation or inflammation to the liver over a period of time, as part of your liver's healing process, it'll start to lay down scar tissue, okay? And I'm gonna make a metaphor to the skin. Because many of us, unless you've lived a very bubble-laden life, have had cuts and bruises from time to time. And if you had a cut or a bruise on your skin, what happens? If you take care of that, your body will eventually heal. But there's a long process between that cut and skin that you didn't even realize was cut in the past, right? So when you first get that cut, what happens? Your body forms that scab. Okay, and that scab, as long as you baby it, you take care of it, you don't do the same thing that caused that cut over and over again, that scab will eventually melt away and form a scar. And eventually, over maybe months, maybe certain years, depending on how bad that initial cut was, that scar may fade away. And for many people, it'll fade away to the point where it'll look like their unaffected skin. Well, the liver can be the same way, okay? And I say that because if something's causing irritation or inflammation to the liver, scar tissue can start to develop as part of the liver's healing process. The thing about the liver is that if you give the liver the opportunity to heal, meaning you can identify that process early, you can treat it and address it, oftentimes, just like the skin, the liver will heal over time. But what happens if the process is not identified early? What happens if even if the process is identified early, but it's raging or uncontrolled? Or what happens over a period of time if the process is not identified at all? Well, then your liver will start to lay down scar tissue, okay? And a little bit of scar tissue, a lot of people don't feel over time, okay? But if the process continues, you get more scar tissue. And if that process continues, you get more scar tissue. And if that process still continues, then you can get complete scarring of your liver. And complete scarring of your liver is essentially what cirrhosis is called, okay? So when we think about stages of liver disease, we think of stages 0 being no scar tissue, 1 being a little bit, 2 to 3 being a moderate amount, and 3 to 4 being advanced, and 4 being essentially complete scar tissue or cirrhosis, okay? So this is another question I get a lot of times in my clinic is, what stage am I? And I always like to say, well, once you get to cirrhosis, unfortunately, the process is not reversible at this time. However, everything leading up until cirrhosis, meaning stage 3, you can, if again, you identify that process early, you can potentially reverse it and allow the liver time to heal. Not always, but that is our hope in many cases. So I wanted to take a pause here and talk about cirrhotic stage liver disease, as far as the history of it and how long we've known about it, okay? And to see and determine how that's changed in 2024. Well, this is Linek. He actually was a physician in the 1600s. So we've seen literature dating back to as early as the 1600s describing cirrhotic stage liver disease. So, and then this is John Brown, who is a surgeon who described it in the OR, the operating room. So basically, what was described as cirrhosis is people being yellow, and then when they looked in the operating room, they noted this glandular appearance of the liver. They didn't understand the disease entity as a whole, but this phenomenon has been described since 1600. It's 2024 and we don't have cures, people. Think about that. So that's why it's really, really important for us to not only understand our history, but see how that can influence our future. And that's why forums like these are so important, because we know this disease has been going on a long time. We know that the suffering, the catastrophic effects of this disease have been going on a long time. So not only do we need to support the disease state and treat patients, but we also need to support our community through this as well. So I put this slide that can be a little bit overwhelming, but I wanted to emphasize that cirrhosis is not just something that you can see on the liver. So these lumpy and bumpiness, remember that liver I had earlier slides that was nice and smooth? This is a cirrhotic liver, but this is what you see if you look at it with the naked eye. But at the microscopic level, you actually see that the liver changes as well. So not only does the liver change at the microscopic level, but the jobs of the liver changes at the microscopic level. Through hormonal mediators and chemical mediators, now the liver is not able to do its function, and that's when people start to see the effects of liver disease, okay? So before we talk about the effects of liver disease and what this means and what individuals feel when they're suffering from liver disease, I wanted to talk about what does cirrhosis mean for life. And as someone who's never suffered from liver disease before, all I can say is that this is on the physician side of things, but it's more than just the words I have on this slide, okay? It's mentally. I'll describe the physical, emotionally, all of those things we know compromises are a result of liver disease. But a lot of times I get the question that is, for my patients, they always ask me, what do I tell my family? How do I help my family understand what's going on with me? What can I do? I want to live. And this is actually one of the most heartbreaking questions I get every day. So one of the things that I have to do is bring it back to science and what I know, okay? And so there are multiple prognosis scores that we utilize. Many of you may have heard of the MELD score, or the modified score for end-stage liver disease. These are a series of numbers, okay? This is not understanding life. This is not understanding your memories. This is not understanding who you are as a human being. This is pure objective data, okay? So when people ask me this question, I say, well, let's look at your numbers and see what that means for you. The MELD score is a score that was actually initially developed to determine folks' candidacy for undergoing a procedure called the TIPS procedure, which we'll talk about in a little bit. But what we have seen is that this is a really good score to understand the prognosis as far as mortality, meaning what is the risk of death within 90 days. What I didn't put on this slide is the risk of death within 30 days, but what I did put on this slide is survival, because I didn't want to have this presentation be shrouded in negativity, okay? So I did this in terms of survival. And these are for patients who are sitting at home. These are for patients who are coming into my clinic. These numbers don't reflect patients who have been in the hospital, who are currently in the hospital being treated for something else, okay? So the MELD score, and if you're good at math, feel free to use and do the calculation, but I personally use a calculator because I'm not that great at math. But actually there's multiple iterations of the MELD score. The most recent iteration of the MELD score is the MELD 3.0, which takes into account gender and also albumin. So remember when I mentioned that the liver creates a lot of things that helps the body go? Well, albumin, or a measure of protein in the body, is one of those. So in addition to using numbers that help that take into account your kidney function and your liver function, we also use gender as well, and that gives us an estimated score. And so everybody without liver disease, with liver disease, the number starts at 6 and it goes up to 40. Theoretically, you can calculate beyond 40, but for the sake of liver disease and understanding the role of the MELD score in transplantation, the number stops at 40. We know the lower the MELD score, the presumably better off the patient is doing. However, the higher the MELD score, we understand that this person's probably in trouble, okay? So I put a couple of benchmarks here for us to understand. So at a MELD 6, again, this is the bottom of the calculator, this implies intact kidney and liver function. Again, this is all implies. This is just numbers. This is not taking into context the human being or the human who is suffering from symptoms of liver disease, okay? So a lot of times we get folks who are sicker than their number implies, okay? MELD 15, this is kind of middle ground. This is where we start to think about, hey, maybe this liver is gonna be in trouble soon. Maybe this human being is gonna be in trouble soon. We need to make sure that we are in an appropriate spot to help this person should they get worse. So whenever MELD score is 15, that's when we start to think about who this person is. Will they need a transplant at some point in the future? When the MELD is 26, the reason why I put this number up here and MELD 29 is because in this region of the United States, the median MELD at transplant, meaning half of the patients get transplanted above a MELD 29 and the other half of patients get transplanted below 29, okay? And again, these patients have, although the number 76.5% 90-day survival does not look as bad, but when you start to look at 30-day survival, that actually cuts in half. When you start to look at patients who are in the hospital, even that number cuts in half. So it's really important that we understand and identify the sicker patients first. And the way we use the MELD score, the way we use the MELD score as far as transplantation goes, is that's the number, we order folks from the number highest because we imply that that person is the sickest individual all the way to the lowest. So that's why the MELD score matters. And then, as I mentioned, MELD 40, these are folks who we know are in dire straits. So these are the key numbers that I put in this. And a lot of times I have patients and their families come see me and they say, well, my MELD score went from a 10 to a 12. Should I be worried? And I tell them, well, no, not so much, because the number gives me benchmarks in my mind. But how are you feeling today? How are you doing today? What's going on? So numbers alone don't tell me your life story, okay? It's the symptoms that help me understand where we are and what we're doing as far as managing the symptoms of liver disease. So with that being said, let's talk about some of the symptoms of liver disease. One of the symptoms I didn't mention here is jaundice, which means yellow eyes, yellow skin, and that's because of flow of bile. Remember I mentioned that one of the liver's jobs is to create bile and send it down into the intestines for digestion. But when the liver is dysfunctional, we know that that metabolism of bile becomes abnormal. So oftentimes we see folks with elevated bilirubin because of a dysfunctional liver. And unfortunately, the body tries to help. It says, well, if we can't process this bile and send bile where it needs to go, we need to send it somewhere so it's not a toxin anymore. So unfortunately, that somewhere ends up being soft tissues like your skin or the soft tissues of the eyes. So jaundice is one of the key symptoms that we do see in liver disease. But the other symptoms that we see in liver disease, when we start to think of how well is the liver functioning or not functioning, we start to think of portal hypertension. So you might have seen portal hypertension, portal hypertension, portal hypertension a lot. This is actually the cause of most of the symptoms we see in liver disease. And what does portal hypertension exactly mean? So remember I said the liver is a giant filter, right? So that means your liver has to see essentially all of your body's blood supply. In order to see all of your body's blood supply, there has to be a vein that sends all of the blood through your liver so it can be filtered. And so when the liver is stiff and cirrhotic, that means it's not elastic. It can't handle all that pressure too well. So when the liver is stiff and cirrhotic, that means the pressure in that special vein becomes high. And then that's where we start to see that the body can't handle that significant pressure. That's called portal hypertension. That's not the same hypertension we think of your arm when you hear folks having high blood pressure. It's specifically of the vein that enters and supplies the liver. And so that's where we start to see the majority of the symptoms of liver disease. And I'll kind of outline that over the next series of my slides. Now, other symptoms of liver disease that may or may not be related to portal hypertension, muscle cramps. Those of you who've gone through it know that can be a devastating symptom that can impede sleep and therefore impede life. Itching or pruritus, because of that bile accumulation, because of the jaundice in the skin. Sleep. I don't think we still have a good understanding of why sleep is affected in advanced stages of liver disease, but we know that more than 2/3 of patients actually have sleep difficulties. Sexual dysfunction, also very common, and pain. Pain due to either the effects or consequences of symptoms of liver disease or due to the primary disease process that led to the cirrhotic stage liver disease. And malnutrition. I won't belabor the point on malnutrition because I think we'll talk about it a lot more today outside of this talk, but these are some of the main symptoms. There are others, but these are the ones I definitely wanted to highlight today. So ascites, let's start with ascites. This is a very pesky symptom, primarily because along with the heart, the kidneys, the liver is one of the major sites that helps your body process fluid in the body, okay? It helps to regulate keeping the fluid not too much and not too little in your body. So as you can imagine, whenever folks have cirrhotic stage liver disease, your body can't handle all the fluid it's seeing. And unfortunately, the body starts to, again, like a teenager who doesn't know how to clean their room, starts to put the extra fluid in places where it has space. And unfortunately, the area of the body that has the most space just happens to be the abdomen. That's usually one of the places where folks struggle with. And with ascites, sometimes it's obvious, but sometimes it's not. So that's why the first steps of diagnosis usually starts with a physical exam. So when folks have ascites, sometimes it can be apparent, like in this individual here, but sometimes not. Sometimes, sorry about the typo, sometimes we use ultrasounds to look for the fluid on the inside, and then paracentesis. Those of you who've had a paracentesis before know that the goal is to create immediate relief of the fluid, but that's not a long-term solution. The long-term solution is multifold. We start with behaviors and diet. You'll hear the word diet and nutrition many times throughout today, but essentially, the first treatment is the sodium restriction. So I want to stop here and emphasize that the sodium that you're eating is not the same sodium that we're checking in the blood. Okay, those are two different entities. The sodium that you're eating is what is the cause of the problem in a lot of patients who are struggling with ascites. Primarily because salt, whenever you have excess salt, your body wants to hold on to fluid to kind of dilute it out. So I use the metaphor, like if any of you cook, I don't cook soup, but if you cook soup, if you cook a soup, I'm told that if you try to cook a soup and you make the soup and you taste it halfway through and your soup is salty, what do? You add water, okay? You want to cut down that salt, so you add water. Well, your body, trying to compensate for your liver, says, hey, if we're eating too much salt, let's add water in the hopes that we can dilute it on the inside. However, whenever you have either heart, liver, kidney, or blood vessel diseases that circulate between the two, or any one or multiple of these diseases, your body can't handle or process all of that extra fluid. And so what happens is that your body essentially stores it. And so that's why one of the first things that we say when we talk to patients who are struggling with ascites, we say, what's your salt intake looking like? Well, we're going to get really good at reading nutrition labels, okay? Because the number one way to cut down on the ascites formation is to cut down on the salt intake. And we usually start with 2 grams or 2,000 milligrams a day, okay? And this is very difficult, okay? Because it's not just about the salt shaker. It's not just about the Morton salt you're putting in your food that when you're cooking at home. It's also about the preservatives. So I usually say, rule of thumb, anything in the middle of the grocery store will automatically have more salt content than anything you make fresh or get freshly supplied. So it's really difficult. Anything you eat at a restaurant, anything you pick up to go, automatically has way more salt content than anything you can make fresh at home. So that's why it's not just about visualizing the salt, it's also about thinking about what is being consumed. Now, let's say, despite a sodium-restricted diet, we're still struggling with symptoms of ascites or fluid accumulation in the abdomen. What's next? We use these fluid pills. So the main fluid pills, and I outlined the diuretics here, are furosemide, also known as Lasix, which is the brand name, and spironolactone, also known as aldactone, which is the brand name. And some people even use medications like eplerenone, which is a cousin of spironolactone. The reason why I outline these medications, because you may have been on one or many of these medications or combinations of these medications. And so we try our best to utilize these medications to squeeze out that extra fluid. Sometimes we're successful, sometimes we're not. But these diuretics can have consequences, right? So sometimes by trying to solve a problem, we can make another problem worse. So this is why when you're on diuretics, we have to make sure that your kidney function is doing well, that we're not squeezing or dehydrating the kidneys. And then when you're peeing out all this extra fluid, the pee is not water, right? You're also peeing out good nutrients. You're peeing out sodium, you're peeing out potassium. So you also have to make sure that you're not wasting all those electrolytes. So that's why monitoring is really important. The next step is if we can't get good balance with the diuretics, then the paracentesis comes into play. That's when we physically remove the fluid by inserting a needle into belly and removing the fluid. It's not uncommon that I hear people say, I got 1, 5, 10, 12 liters of fluid off. from the, and it can be, and if you can imagine, 1 liter of fluid is 2.2 pounds. So this can be a lot. So as you can imagine, suffering from ascites is a lot. It's a lot. It's a lot. It's a big deal, which is why we do our best to treat it and aggressively if we can. And even if we try all these measures and we still are not getting good fluid control, sometimes we do a TIPS procedure, which is a transhepatic shunt procedure, meaning we basically create a conduit to help the liver offload some of this pressure. So this, and I basically have a slide on it later, but basically, how do we bypass the sick liver? Okay, what can we do to make sure that the liver can handle this fluid a little bit better? And it's basically about bypass route. So instead of all the fluid going to your liver, we bypass it so that it doesn't see as much, and so your body can handle and process it a little bit more. So there's multiple ways in which we can treat ascites, and you can see because of these multiple ways, it's case by case basis. So one person may have all of these things, one person may have 1 or 2 of these things, but it's something that we pay attention to and ask about in every clinic visit. Hepatic encephalopathy, you talked about that earlier. It's one of the more devastating symptoms of liver disease, primarily because your loved one doesn't act like your loved one anymore. It's someone you can't recognize anymore. And it's based on, and it happens as a result of a very sick liver. So why does hepatic encephalopathy occur? So remember when I said the liver is a giant filter? One of its jobs is to keep the good, get rid of the bad. So what happens if the sick liver can't get rid of the bad as efficiently or effectively as it should? When the bad hangs around a little bit longer than it should, sometimes those bad toxins can go to the brain and alter the brain's chemistry. And anytime you alter the brain's chemistry, that leads to confusion or encephalopathy, which is essentially confusion related to liver disease. This is not just confusion when you're walking into a room and you're like, what did I come into this room for? This is not the kind of confusion when you're like, where did I leave my keys? No, this is altered brain chemistry because of a sick liver. So it can be very subtle. And I'll go to the next slide. It can be very subtle, where it can start off as mixing up days and nights, meaning you are up all night, sleeping during the day, tired, fatigued for no reason. It could be brain fog, feeling like it's wading through your thoughts and you can't really put your words together like you should, or like you feel you should. And then it could be very obvious. So the obvious is when it's later stages of the encephalopathy. This is when you're not knowing who you are, where you are, what's going on. And in its more severe stages, it can be even representative of comatose or unresponsive individuals. So how do we treat it? Well, understanding why it happens is key, number one. Number two is understanding triggers. So there are certain triggers for encephalopathy or precipitants of encephalopathy. The biggest thing is bleeding. So anytime there's something that offsets the balance of the body, then that leads an individual struggling with liver disease at increased risk for developing encephalopathy. So bleeding anywhere in the body really, but particularly within the intestinal tract is one of the triggers. Infection is also another trigger. You might not believe it, but things like constipation or dehydration, also a trigger. Things like electrolyte abnormalities, also a trigger. So basically anything that offsets the balance of the body can be a trigger. So that's why whenever someone is confused who has liver disease, it can be a medical emergency. Because I like to think about this like a carbon monoxide detector. How many of you have carbon monoxide detectors in your home? Good. It should be everybody, hopefully, after this talk. But essentially, if that carbon monoxide is an odorless, colorless gas, right? But if your detector goes off, you're not going to sit there and say, oh, I hope it gets better. I hope it turns off by itself. No, you're going to leave your home and you're going to have someone get it checked out to make sure you're not having that poisonous gas invade your home. Confusion in the liver, confusion due to liver disease is essentially the same thing. It's your body's way or your body's signal of saying something is not right. Even if you're not able to feel something, a specific symptom, it's your body's way of saying something's not right. We need to go get checked out. So that's why anytime you're having increased confusion, or anyone, if you have a loved one who's struggling with increased confusion, it's not just about giving lactulose or rifaximin. It's about making sure nothing else is going on, okay? The main treatments for liver encephalopathy are lactulose, 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 which lactulose is not pleasant. If you've tried lactulose, and again, I've tried lactulose, every medicine that I prescribe, I at least try to try it. I know it's not pleasant. It's a sugary, sweet liquid, but it's very important to make sure that if your liver is not able to process those toxins, we need to give you something that helps the bacteria in your intestines kind of soak up those bad toxins and get rid of them or process them through your body. So lactulose is one of the main medications that we have that can do that. And the only way we know lactulose is working is if you're having sufficient bowel movements to the tune of at least 2 to 3 good-sized bowel movements a day. Not little pebbles. I know this sounds morbid, but it's true. Not little pebbles, but good-sized bowel movements, which should absolutely take up about 1/4 of the toilet bowl. Rifaximin is a old school antibiotic that doesn't necessarily rely on your bowel movements to work. It stimulates bacteria in a different way, but really also picks up those toxins. So as long as an individual is taking rifaximin, we know it's working. There are other studied agents, which I listed down here, but these haven't necessarily been scientifically shown or replicated in large clinical trials. Branched chain amino acids is one that looks promising, but it's not necessarily routinely recommended for every patient unless they're struggling despite use of lactulose and rifaximin. So now let's talk about other symptoms of liver disease. So we talked about ascites, which is fluid accumulation in the belly. We talked about liver encephalopathy, or confusion on the brain related to liver disease. Now varices. So remember when I mentioned that a stiff cirrhotic liver can't handle all that pressure? That's called portal hypertension. Your body tries to preserve that pressure balance. And the way it tries to preserve that pressure balance is by creating accessory veins, or little side streets. The metaphor that I use in this scenario is kind of like if you're taking a highway, if you took 65 or 24 here, and you know that 4 or 5 lanes are blocked off ahead. Well, what do? You say, let me get off the exit, take the side roads to get to my destination, right? Let me avoid that congested area. Your body does the same thing. Your body tries to be smart and kind of help create that balance. But unfortunately, sometimes that balance can cause other problems. So when you create those accessory veins can go places, and I don't know how to point, so I might just walk away. Those accessory, it's okay, we'll figure it out. Okay, look at us. All right, so those accessory veins can go to other places. So this is the portal vein, which is the big vein that goes into the liver. But when this pressure gets really high, those accessory veins can go to the stomach. When they go to the stomach, that's called gastric varices, or varices in the stomach. When they go to the esophagus, those are called esophageal varices. Now, if the pressure gets intense or excessive, those varices or veins can get bigger and bigger and bigger. And if they're under significantly higher pressure, they can rupture and bleed. And that rupture and bleed can be life-threatening and catastrophic, one of the most catastrophic symptoms of liver disease. And the way that that bleeding can be manifested could be throwing up blood, pooping blood, or having black road tar-like stools. So whenever any person who's living with cirrhotic stage liver disease or their caregiver tells me that they've seen any form of blood, it's important that we understand where it's coming from. So the treatment for this depends. So number one, we need to understand, does this individual have varices to begin with? So that's why oftentimes the first rule is we want to be prevented as we can. We want to prevent these bleeding episodes as best as we can. So number one, understanding, do varices exist? So oftentimes we recommend endoscopy, or taking a long flexible camera looking at the upper GI tract to understand if these varices exist. If someone has not had bleeding from these varices, either we place rubber bands at the site to make sure they don't bleed, kind of like a tourniquet effect, with the hopes that we can scar down that tissue and reduce the risk of bleeding. Or we can use medications like carvedilol, propranolol, nadolol. These are medications that we hope can reduce the pressure supplying these varices here in the hopes that we can reduce the risk of bleeding. So that's one way. We have options if someone hasn't suffered from bleeding from these varices. However, if someone has had bleeding from these varices before, we don't have options. We must act, because we know this is life-threatening. So the treatment at that time means to go inside and take a look, put rubber bands here, kind of like a tourniquet, to cut off the bleeding on the inside, and then on the outside, we use medications to reduce the pressure that supplies these varices. So whenever someone has had bleeding from these varices before, then we need to absolutely do both, okay? And then sometimes the tip shunt is needed to actually cut off all that pressure supply going to those varices. So the tip shunt, as I mentioned, is a bypass route. So instead of all the blood flow coming into your liver, getting processed through your liver, leaving the liver, going to the heart, and getting pumped again, what happens is that the tip shunt creates a passageway. So the fluid comes into the liver, we skip a step, we skip all the liver's tissue for the most part, in the hopes that we can bypass all that cirrhotic and fibrotic changes in the liver so that we can reduce the pressure that way. So basically, it's a stent or a created connection between these two blood supplies in the hopes that we can reduce the risk of bleeding. So that's another way that we can reduce the risk of bleeding long term. One of the other complications of cirrhotic stage liver disease is also liver cancers. And I know you shared this story, and then you'll hear from other folks later today as far as their stories about struggling with liver cancers or watching their family members struggle with liver cancers. Whenever someone has cirrhotic stage liver disease, they're automatically 20 times higher risk of developing a liver cancer than someone without liver disease. And so we know that this is problematic. However, with liver cancer, we recommend that we monitor every 6 months in the hopes that if there is a propensity to develop liver cancer in a patient struggling with liver disease, we catch it early. Primarily because we know that if we can catch a liver cancer early, we have multiple treatment options. Transplant is also a potential treatment option. And when I say treatment, when it comes to transplant, I mean curative options when it comes to that. But we have to catch it early. The later we catch a liver cancer, the less options we have. So for this reason, we actually recommend screening for liver cancers every 6 months. And that screening for liver cancer can be in the form of getting ultrasounds every 6 months, getting CTs every 6 months, getting MRIs every 6 months, or a combination of the two, okay, or a combination of the three. So it's really, really important that not a 6-month period goes by without looking at someone's liver, because we want to make sure that if they do develop a liver cancer, we have an opportunity to treat and sometimes even cure with transplant. So how do I fix this? Is there a cure? Unfortunately, no. So 1600s to 2024, we do not have a cure for cirrhotic stage liver disease outside of liver transplantation. So we focus on management. We focus on therapeutics. We focus on how does someone struggling with liver disease, how do we make them have somewhat of a fruitful life so they're not struggling from these symptoms. So the key is nutrition, which we'll talk about a little bit today. Low sodium diet we talked about as it pertains to ascites or fluid accumulation in the belly. We only do fluid restriction or free water restriction if someone is struggling from low sodium in the blood, but really keeping a well-balanced diet is key. And I always tell folks that anything that's good for your body overall will inevitably be good for your liver. So I won't belabor the nutrition key points and facts because you'll hear about that later today. Mental health is big. Again, we heard about it during our last talk, but mental health, mental health, mental health. This is not easy. This is difficult, not just for the person struggling with symptoms of liver disease, but the family, the friends, the community that is surrounding this human being. So we are understanding the importance of identifying mental health disorders and treating them early. And then other things like healthcare maintenance items, making sure that we are up to date with vaccinations. I always get the question is, should I get these vaccinations? Are they going to be hard on my liver? The answer, for the most part, is no. We recommend all age-appropriate vaccinations, including the COVID vaccinations and their associated boosters, in folks who are struggling with long-term liver disease. So what does liver transplant mean? So again, when will I need a liver transplant? These are the two questions I get. So let's talk about the indications, or who do we think about liver transplant for? So as pertains to this talk, again, someone who is struggling with complications of cirrhotic stage liver disease and symptoms of liver disease, we're always thinking about when is the right time to replace this really, really sick liver? When do we need to move forward with trying to understand who this human being is? There are other complications of liver disease that I did not talk about here, but again, making sure that we understand who the human being is and how awful the liver disease is really is the trigger for understanding, are they someone we need to think liver transplant for? And then liver cancers as well. We use the MELD score, as I mentioned previously, to give us a hint as far as when the appropriate timing is. So usually a MELD 15 or above for most cases, not all cases. The exception to this rule are for folks who are struggling with liver cancers. I don't care about the MELD score if you have an early stage liver cancer. I'm thinking about replacing your liver. And then the other thing is, how do I get a liver transplant? So this is a very scary process. We know that. It's terrifying because it's not just about you coming to see one provider, you get on the list and you get a new liver the next day. That's not how it works. It's not like a gallbladder surgery where you go in with your bag, you check in, you get your gallbladder, 15 minutes later you're in the recovery room, you leave, you go home. It's not just that either. It's a complicated process. So the pre-transplant evaluation starts off with actually understanding the liver disease. I should have put here first. Understanding the liver disease, understanding the nature of the liver disease, understanding the symptoms of the liver disease is first. Then a very astute family individual provider makes the initial referral saying, this person's sick, I need to get them a new liver. And then outside of that, it's not just, are you sick enough? Should we proceed? There's other circumstances that we need to consider, like finances. Is this human being going to be someone who could afford? Do they have insurance? Other things like medical evaluation. Is this human being healthy enough to get a major operation or procedure? Basically, is their heart strong enough to survive this? So it's not just about, do you need a liver? It's like, are you healthy enough to get a liver? Is it something that you could survive long term? So our surgeons help us understand that as well. Anesthesiologists, how do we keep you sedated and comfortable during the procedure? How do we keep you stable during the procedure? And then outside of that, things that we need to make sure we set up every patient and their family for success. Psychiatry for the mental health abnormalities we know we see, social workers to help understand some of the complex nuances about liver disease that are not just medical, not a lab that we can check, and nutritional support. So it's a big, long process with multiple members of the team. And then who will take care of me? Who will take care of me? So this is the part at which I ask. Most times I see patients in my clinic and they come with some support, or they're Sherpa. They come with that individual. And I say, well, you have to look around you. Who loves you? Who's there for you? Who's at home with you? Who do you feel like are integral members of your life? Who is your partner? Who's your family? Who's your blood? Who's not your blood? So those are the people who help all of my patients care for them when they're not directly touching a healthcare provider. But whenever they're within the care of a liver specialist or a hepatologist, the hepatologist is the one for the most part driving and helping understand the symptoms of liver disease, managing symptoms of liver disease in the hopes that we can prevent the awful effects of liver disease. So I have a lovely team at Vanderbilt who I consider family, honestly, to help take care of the community as a whole. I always put them as my teachers, my role models, and things like that. But this is our hepatology team at Vanderbilt. They are amazing. If I had liver disease, I would go to any one of them. But you're not on an island. Families are not alone. The community is not alone. We're here to help. So I know this was a big presentation that took a lot. It's just the very tip of the iceberg as it pertains to liver disease. But understanding why it forms, understanding some of the complications of it, and also understanding that there is hope for treatment and cures in transplant. So again, this was a short presentation for a big topic, but hopefully I answered most of your questions. I'm happy to take more questions if there are any. Thank you all.